Hello, I would like to introduce my colleague, Dr. Natalia.
Thank you.
Natalia Spierings is my colleague consultant, a dermatologist who is very well known through the Instagram with her informative content.
Instagram.
And also, apart from that, additional training in skin surgery, more surgery, which is a very precise way of cutting out tumors from head and neck and cosmetically essential parts of the face.
Mm-hmm.
I think we already talked in another episode, but to mention, it is additional training in an accredited center in the UK, and you can basically remove the tumor on the day and precisely know it's out and reconstruct with a minimal sort of disfigurement of the area, like eyelids, nose, lips.
Yep.
Apart from that, Dr. Natalia wrote a book, which is signed nicely for me, and lots of answers to most commonly asked questions already in there. So nice to see you.
Nice to see you too. Thank you for the introduction.
Today, I think we're aiming to talk about evidence, papers, publications in dermatology in regards to skin conditions, most commonly like acne and food, hair loss, minoxidil, atopic dermatitis, sunscreens, whatever evidence available, we're just going to discuss, right?
Yeah, and I also think it's interesting for people to know that this is something we would normally do. Like a journal club is part of usually most dermatology departments, well, at least in the UK. And so this is like our version of the journal club because we don't have enough doctors to participate. But you can do it with 2 people. That's totally fine. So Dr. Volha is the one who found all the papers. So that's
no problem.
That's they're very interesting papers. And yeah, that's the point of this, is that we discuss the evidence in the paper. And it's interesting because I just had a chat with a journalist who said that the chemists on Instagram, I don't know if you follow them, the cosmetic chemists. Mm-hmm. So they came out with a statement recently saying that dermatologists don't understand cosmetic science because they don't know how to read trials and science in papers.
That's very bold statement.
Yeah, and that we're not trained in it. And I'm like, I damn well sure was trained in how to read a paper. That was part of my medical school education, but also as a dermatology registrar, we did a lot of this stuff, like journal clubs and things.
I think it depends what dermatologist from which part of the world you're talking about.
Yeah.
I suppose you cannot just group everybody into one.
Absolutely not.
One lump.
And also, some doctors do special training in like statistics, medical statistics, and I have friends who've done a master's in that. And anyone who's done a PhD will have a very good awareness and knowledge how to read a clinical trial or a scientific paper. So I thought that was a bit of a slag off of our specialties, our
you see, first of all, as a part of training in UK for the CCT, you have journal clubs.
Yeah.
You have to attend a course, like B's course. Or
of course, I did that too. Yeah.
Yeah, so this is how to understand the paper, how to read the paper, different types of papers. And we had to practice how to actually, there are tools, how to appraise the paper, CASP tool.
Yeah.
Right? So different paper has different CASP tool. Secondly, some people go on to research publications, co-investigators in trials. You and me, we did masters. Some people do PhD. So certainly without appraising a paper, you can't do any of that.
You can't do any of that. But you can't really practice medicine either. So the idea that we don't know how to read a paper, I mean, all doctors know the basics of reading a paper. Some people perhaps aren't as good at reading methodology or understanding that. But generally speaking, we are trained, and we have to be trained in how to read scientific papers. Otherwise, we can't do our jobs properly. Anyway, I thought that was a bit. So this is part of how we learn as doctors in a very practical way how to use papers to, help our practice be better or perhaps changing our practice. So that's what we use papers for, and we try to stay as up to date with things as possible. But yeah, so anyway, this is part of a normal kind of, when you're consulting, we still continue to do this. Because it helps us stay up to date.
When you're in training, you have to read the book, you have to prepare for exam, you're on your peak of the knowledge, kind of. Then you become consultant, you're on your own, you're the one who gives second opinion. How to stay up to date. Books are old, at least 4, 5, 6 years old.
True.
So you do have to keep up to date, like BAD journal, British Association of Dermatology. American journals, European, and every so often you sit down, open the journals, and they read what's of interest, or you Google or on PubMed when it comes up to PubMed.
It's easier than journals.
Yeah, you search. I say Google. You basically search the topic you need to research. Like if you had a patient with something association rare disease, so you basically use the PubMed. Then you open the journal, which gives you all this citation. I still aspire to have that kind of discipline every morning, half an hour.
Oh my goodness.
With a coffee to open and read.
Oh.
But I know very experienced doctors.
Wowzers.
They in the morning, half an hour to an hour, they open and read the papers. So I still aspire to that, but majority of my time I research when I need to, or maybe once a month I sit down, see what's new.
Yeah. I mean, I generally go into papers when I need to find out something. So when I research things, but I can't believe, I mean, that would be a life goal to be able to sit down every morning and have a flip through a journal. I mean, do you get the journals here? Because I don't get the
online.
journals.
So
get the online access.
You get through in the UK Royal Society of Medicine, Royal College, BAD, and here you get through DHA. Library.
Yes. Oh, okay, yeah.
You can subscribe.
I have to subscribe to the DHA library.
So they have quite a good choice there.
Yeah, that's helpful. So no, the dream of every doctor is to have even an hour in the morning before you start clinic, before you do anything else, to sit down and be like, oh, let's just see what's happening in the world of dermatology today.
And to be honest, when you start doing that, you get really sort of infused, and then you think, oh my God, I have to go to clinic. Like I have to interrupt my reading.
Yeah, I don't want to stop reading, because in the bottom line is all doctors are kind of geeks. So we like to. I wouldn't mind having a day just to sit home and like read stuff and kind of think about it, and that'd be great, but obviously no one has time for that, but maybe in the future we all will. But anyway, so that's just an intro to what a journal club is, and understanding that we do this as a regular part of our training, and then afterwards, and it's nice that this is your idea to do this, and I think that's great, because I haven't done a journal club for a couple of years. So,
it's a way of kind of making time to speak to other people, discuss evidence, because sometimes perception from person to person varies how they perceive the paper. Even when we did training in journal club, some people read the paper this way, some people understood it that way. It's quite interesting debate.
Yes, it makes
especially
it
poorly designed papers.
Yeah, poorly designed. That's understanding why they're poorly designed. So, but yeah, anyway, so I think that's a good intro. So should we kick off with the
so it's important to understand for everybody. So there is a triangle of evidence, like strength of evidence. So the highest evidence is systematic review, meta-analysis. Basically, it's a review of all RCTs, randomized controlled trials, lumped together and looked at, it depends on the topic, right? If it's atopic dermatitis or some acne, whatever topic it is. So then obviously as we go down the ladder, it's the evidence quality or strength drops.
Yes.
And the lower evidence is the expert opinion, key opinion leaders, or my expertise or my gut feeling. It's the lowest one. So then above that,
evidence for anything. So unfortunately, yeah.
So the case control studies and case series or case reports just slightly above that. And normally I would say case reports, it's a good background in order to form a question for the actual proper trial.
Yeah, and that's I think where lots of trials and medications and stuff come from, is the case controlled. So it's important to publish those.
Yes.
Yeah, when you have one really odd thing, someone else might have had it in another country, and then they read your paper, and then you communicate through that about that, which makes it an open discussion about the paper, about a patient.
Yeah, for example, like now more and more case reports, even on Instagram, coming out of the injection of exosomes and the irreversible papular granulomas.
Oh yeah.
So I think that will make its way into possibly bigger trial in the future, how they should be applied. Same with almost anything, right? Kind of case report side effects, and thalidomide, if you remember, they used to give for nausea, and then baby's born, and then all review has happened. So the case report is good as a starting point, and just to be aware of.
But that happened with Roaccutane, because there were, I think, 2 case reports back in the 80s or 90s of 2 teenage boys who had, successfully completed suicide. Successfully, you know what I mean? They completed suicide, and they were on Roaccutane and had severe acne. And that's where that started, the whole concept of Roaccutane causing mental health problems. From what I understand, I don't know if you have the same, but came from those 2 case reports.
Yeah.
And then it kind of went huge after that. But there's been a lot of work that spurred on looking at giant retrospective studies, observational studies to see
Yeah.
what the correlation really is. So and that can be a problem as well. But at least it sets off a point for discussion
Yeah.
or for further learning. So yeah, case reports are good, interesting. I always like reading case reports, especially if they're pictures.
Yeah, case reports is like real life learning.
Very real life learning, exactly, exactly.
From others.
Yeah, definitely. No, we like case
And
presentation.
regarding this Roaccutane, it has sparked fear, but in real life, we see like hundreds and hundreds of people per week, especially in NHS.
Yeah, literally.
And even people who have severe depression on medication or learning difficulties, they do great on medication. Close observation, correct education. But the question is, does severe acne cause depression?
Well, yeah, I think we know that's true. I think that's pretty well evidence-based.
So you can't be sure what actually caused the trouble.
Exactly. So it's difficult, and this is how I often explain it to patients. Like, it's difficult to, unpick that, because mental health problems are so complicated and multifactorial that to blame it on just one pure thing, like one medication, is just, that doesn't even make sense. Like, it's not. You're trying to say if you can blame it on one medication that mental health problems are due to one thing only. Which anyone who suffered from a mental health problem, whether it's depression, anxiety, or anything along that line, knows that it's just not one thing.
No, it's multifactorial.
So it's multifactorial. So, and the fact that it scares patients from taking or even looking into it, that's a huge problem. So, I mean, people are not getting the treatment they need because they've been scared by the Daily Mail or TikTok to not take a medication. Actually, is very safe and effective when taken correctly.
It's misinformation.
It's misinformation.
I often see patients, no, I'm not Roaccutane. I don't want Roaccutane.
No.
And I said, that's fine. That's fine. No problem.
Yeah.
But let me tell you about medication and let me give you information.
Exactly.
And you make informed decision from reliable sources.
That's exactly what I
And then
say.
next time
like
we see how current treatment working, and if you have any questions. And then very often, like 90% of people, when they go on Roaccutane, they said, I don't know why I was
so scared
fearful.
and why I waited so long.
So scared about. And they do extremely well, and we actually will be talking about
in a paper,
Roaccutane in the paper.
Yeah, actually that's the first paper.
Yes.
About dosing.
So yes, is acne relapse and what factors kind of influence that, isn't it?
Yeah, so it's the biggest fear. You probably have this too. Patients are on Roaccutane, they're happy, their skin is clear and it's perfect, and they're like, "Don't let me stop it. I don't want it to flare up again. If I stop it, how do I know I won't flare up again?" And I always say, okay, well, if we do the correct length of treatment dose and you get to a good amount of clearance over a certain amount of time, then probably you won't have a relapse or it will happen again, but it's always possible. But at least this paper is interesting because it does give you more guidance on that specifically. Yeah. So yeah, good, this one.
So this is the paper from JAMA Dermatology, Acne Relapse and Isotretinoin Retrial in Patients with Acne. So it was recently published and in 2025 actually. So basically this paper looks at a huge number of patients, just almost under 20,000. And they're looking what factors influence on acne relapse, genders and dose and the maximum cumulative dose. So basically, when I prescribe Roaccutane, I calculate maximum cumulative dose based on a weight. So every patient will have their own cumulative dose. So you cannot compare yourself to another person who had Roaccutane.
And it's based on body weight in kilograms.
Correct.
Times a certain number.
So it's between 120 to 150 milligram per kilogram, but this paper even mentions 220 milligram per kilogram in certain cases.
That's a lot.
So it's quite high dose.
Yeah, that's quite high.
So basically the conclusion was that the higher cumulative dose kind of may benefit and reduce risk of relapse.
So basically the more you take. So
the closer you are to your total cumulative dose, and they say the higher, so basically instead of 120 maybe 150. And the dose we give every day, initially we thought it has to be close to milligram per kilogram, but now it says actually it doesn't make a huge difference. But suggestion was 0.5 milligram per kilogram. If let's say person is 60 kilos, we start with 30 milligrams. up to 1 milligram per kilogram, but it's high dose, and people tolerate that quite, not all old people tolerate
that
because of the severe dryness, nosebleeds, chapped lips, all that kind of stuff. So basically, the total cumulative dose is the goal post for the aim.
Yeah, it's just called a goalpost. Yeah.
So because in the past we said, if you're acne free for 3 months, but let's say they're acne free after second month of treatment, then 3 months is 5, and they halfway through their cumulative dose, certainly now we know they will relapse. Most likely.
Yeah, I mean, I never stop anyone. When people ask me how long am I going to be on it, I say usually 6 to 12 months or a little longer. I don't really use the numbers. I kind of ballpark it in my head, but I do this. I wait for them to be. I tell the patient your end point, roughly, is when you're clear of acne for 8 weeks. If they get to that point within 3 months, they're not going to stop it. Like, I know that they can't stop it then. We just keep going. So, but patients always say to me, when am I going to end it? So I give them that clinical endpoint for themselves, but we don't necessarily stay with that because I've never given anyone less than, depends on the patient, but definitely not less than 6 months. Whether it's for acne or whatever it may be. So
usually 6 months plus.
Plus, exactly.
If they take small dose, then obviously longer. So I, since my training, I have been calculating 150 milligram per kilogram. That's my total cumulative dose for each patient.
So let me just say, so if you weigh 70 kilograms average, and you need to get to 150 milligram per kilogram, that means your total cumulative dose is 10,500 milligrams.
Yes.
So if we divide that by, say, 20 milligrams a day.
By 30 days.
I did it by 20 milligrams a day. So that's 525 days of treatment. You divide that by 30 in a month, that's 17.5 months of treatment.
Yeah, so if you take small dose, obviously you take you longer. That's what I explain to patients. Yeah. If you take double, it will half the length.
But you might have really bad dryness.
Yes, but it's, I find when I start people, I start very small dose first month, they get into it, and then we increase to the dose they tolerate.
Yep.
And even small girls, very petite, 50 kilos, they go to 40.
Yeah, they can still go to 40.
But, nicely, slowly.
You don't whack them on 50 milligrams on day one.
No.
That's crazy. No, we don't do that. It does mean that like 18 months, I guess, would be your average. So I usually don't go above 20 just in my own clinical practice because I don't like to have patients with side effects, like bad dryness. So that's just how, everyone does it a little differently, but that's how I do it. And I think 18 months would be a good average for how long patients are on it.
Yes. A year at least.
Regardless, with the 20 milligrams. I just don't put people on higher doses than that unless, there's certain situations because of the dryness symptoms. And that always freaks people out. I find that the dryness is a real issue, like much more than anything else.
Yeah, it's the most common. There were some publications that dryness can persevere for a few years after isotretinoin stopped, especially eyes.
I guess in the question there is, then if you're on a lower dose and you don't get super dry during your acne treatment, does that mean you're unlikely to have ongoing dryness in the long term or for an extended period of time? Yeah, we don't know the answer to that. See, this is why journal clubs then create more questions.
Yeah, we maybe need to go and research on that.
Because that's a great question. People are always worried about long term, and I'm always like, there's not really any long-term negative side effects of Rectine. I'm talking like 20, 30, 40 years down the line. But for a few years, I had residual eye dryness after I took it, which lasted a while. But I think that would be an interesting thing to be able to show, is that if you keep your dryness based on your own dosage to a minimum, then will that mean you won't have issues with dryness down the line?
That's the question.
Should we write that down somewhere?
Yeah, that's the question to
that's
research.
That's the question to research, because that would be reassuring for patients too.
Yeah. But I tell every individual patient, you cannot compare yourself with another, your brother or sister, because everybody has such an individual, even twins.
Yeah, totally with twins. Yeah, they get individual responses. Which is always that's so weird actually with identical twins. But I think this paper is interesting because it does. Not prove, but it agrees with what we already know in practice, but it also gives kind of a more interesting kind of viewpoint on that as well, and especially the bit where they say that lower daily doses may still achieve similar rates of acne remission if a sufficient cumulative dose is reached.
Yes, the key is cumulative dose. If you take it year, 6 months, or year and a half, as long as you reach this 10,500 for 70 kilo person.
No, this is an interesting one. I think it's important for patients to realize too that don't be like, oh my God, I can't be on it for more than 6 months. Because usually when I say 6-12 months, roughly, probably more than a year, they panic because they don't want to be on a medication for that long. So,
but this is the not antibiotic. It's,
yeah, well,
it's
not
a
exactly.
different.
It's different. Oh, but I don't like taking medicines. That's what until they start taking Roaccutane. They're like, I love medicine.
Yeah, it makes my nose smaller.
Yeah, it makes my nose smaller. Oh my God, my fine lines look better.
Yeah.
So anyway, it's a great drug. It's a very safe and effective medication when taken correctly, and you can kind of balance out the side effects with the correct dose. And that your doctor can obviously guide you through that. So
yeah, under supervision, and preferably patient needs to stay with the same clinician. The reason is when we do the depression questionnaire, obviously, and we even can spot person when they come and they don't look themselves. If you say, if the same person seeing you all the time, so they can spot and say like, oh, you're a bit low today. Yeah, I feel a bit. Okay, maybe drop the dose or, kind of thing. And another factor which I find extremely important is adherence, because people take it for a few weeks, drop it for a few weeks. This actually doesn't work as effective as if continuously been taking.
Continuously.
So this is kind of important. And I usually consider after a couple of weeks, if they missed, it's kind of new course. Yeah. Because you just started all over again.
Yeah, so what is it? So I have patients who miss like 2 months. And so when is it that you start a new course? I start a new course if they've missed more than 4 weeks. So if they and then I'm just like, okay, now we're starting from the beginning again.
Yeah.
I mean, I don't know what you do about that. Is it what's your?
I usually say 2 weeks is okay, but it's no kind of guidance on that. But it's common sense, how long it hangs around. We usually say, if you plan children, stop for a month.
Exactly. So that's why I say 4 weeks.
Yeah. So then it kind of wears off in a way, and you start all over.
It's a lipid soluble drug, right? So it sits in your fat. So it takes a long time for it to go once you stop taking it. Like 4 weeks, basically.
Yeah. But it doesn't affect fertility. That's what most people fearful of. It does affect baby development, like when baby folding.
Yes.
That can create defects. And usually termination of pregnancy in all cases. Therefore, it's quite, in the UAE, it's a semi-controlled drug for this purpose. But it does not affect fertility.
Correct. And that's so important, especially for moms giving it to their teenage girls. They're so freaked out about the fertility thing. I'm like, it does not affect fertility. You can't say it's not a hormone, though. That's the thing, because vitamin A technically is a hormone. So, but that's confusing. But not a hormone that affects like estrogen, progesterone type period hormones. Yeah. So I also had a patient this week actually, who a young lad, and he's into the gym and everything, and he Googled whether whether isotretinoin affects testosterone levels, and what ChatGPT said, because we all know ChatGPT knows what they're talking about. It said the first sentence is isotretinoin can cause hormonal disruption, and so he only read that sentence. He said, okay, I can't take it now. Because it affect my hormones. But if you read on, then it says, however, not directly.
Yeah.
So,
however, not that.
Yeah, not direct. Exactly. So you have to read the second sentence, guys. So not directly. I'm like, exactly, not directly. It affects how the androgen acts on the sebaceous gland. That's how it's indirect. It's a hormone, but it's indirect. So it's not going to lower your testosterone levels. It's not going to affect you in the gym. It's not, tons of bodybuilders take Roaccutane anyway. So I tried to reassure him, but it took a long time for me to get over that, because people believe what they read in ChatGPT more than they believe what we say in many cases. So I had to show him it and show him the second. You have to read the second sentence. He got it at the end.
Yeah, we already discussed that AI can be fibbing, dreaming, and can be making up the evidence. When I was doing my research, and those references ChatGPT suggested it did not exist, simply did not exist. So it made it up.
Yeah. Well,
so the question, is it actually so reliable or not?
Yeah, and when I Googled, when I ChatGPT who's the best dermatologist in Dubai, it didn't come up with me or you. So I know that it obviously doesn't know what it's talking about. So I've discredited ChatGPT ever since I researched that topic. But anyway.
Well, it's already 2 or 3 years out of date, ChatGPT.
Is it really?
I think it's lagging behind. When you ask what date, whatever, it tells you 2 years behind. So it's not very up to date.
So Google is better.
PubMed, I think.
Well, for us, PubMed. Yeah,
but for the patients, Dermnet NZ.
Yes.
And bad.org.uk.
Yeah, those are the two references you should go to.
Reliable. If you need anything,
information.
Those two websites, please read those. Don't read anything else.
Don't read anything else. Don't read.
And speak to your doctor.
Yeah, how about just speak to your doctor? All right, cool. So, the next one's also about acne.
Yeah, this is a very quick one in British Journal of Dermatology,
Yeah.
2025. So it basically says acne is obviously an inflammatory condition, but taking omega-3 can help lower risk for acne, but omega-6 is not.
Oh, that's tricky though with when you supplement and eat food.
Yeah.
Because I think the supplements are omega-3 and 6 combos. I don't think, can you buy just an omega-3? I have no idea.
I think it's vitamin D with omega-3, I think
Is that
they
what it
have.
is?
Yeah.
Okay, because I know I take an omega supplement, but that's not for acne, but I take it for general health because of all the supplements that you can take for general health and muscles and whatever. Omegas are the only ones that any evidence base. So this is interesting that it can help. But how does it help?
It doesn't actually specify. It's basically it's like a condensed information.
Right.
Yeah, and I think it goes through the look at the different studies.
Oh, so like it's systematic. I haven't seen this paper. So it's systematic. It's not a systematic review. It's not systematic.
No, they're looking at a couple of studies which were published. Kim et al. Published in BJD provide evidence of role of this and this and that. So they basically bring a couple of studies by this author. And I don't think this is a concrete evidence, but this is the kind of observation they made.
Yeah, so, I mean, this is a much bigger topic, though, talking about food and acne.
Yeah, we've got the papers.
Oh, we have those papers too.
Yeah.
Okay, yeah, we have those papers
Food,
too. Those are the ones I have here, actually. I like to read things on paper, by the way. That's why I print things out.
Problem.
I'm old school. But yeah, it's such a huge topic, the impact of diet and nutrition in patients with acne, diet in dermatology, diet and acne systematic review.
Yeah.
I mean, it's like never ending, and it's all mixed information. So
all three have mixed information.
All three are mixed information. But they're systematic reviews, right? So the studies themselves are all confusing within them. And that, so basically the conclusions drawn, I mean, when I went through these, my conclusion was, I don't think it really matters that much because we can't pick apart what is relevant or not relevant. I mean, I think generally we know that high sugar intake, high simple carbohydrate intake, and dairy being considered to be like a simple carbohydrate. Technically, lactose is a sugar. Anything sugary can exacerbate any inflammatory disease. So is it relevant to acne only? No. So should you eat a low sugar diet? Well, yeah, for general health. If it helps your acne, fabulous. But for general health.
Yeah.
I mean, what's your conclusion?
Yeah, there is a study, Diet and Acne Systematic Review in American Academy of Dermatology 2022.
Yeah.
So basically, they looked at 410 articles and 34 met inclusion criteria. So they scanned quite a lot of articles.
That's a lot of articles.
Yeah, and only 34 were relevant. Basically, they concluded that high glycemic index.
Yeah.
Basically, if you take too much sugar, glucose, carbohydrates, it significantly impacts the inflammation, right? So acne or whatever, psoriasis or HS, hidradenitis suppurativa. Also, dairy consumption, as you mentioned, can be increasing acne inflammation. But it doesn't actually stipulate that you have to cut out all kind of foods.
No.
It just basically, I tell my patients, fast food, fried food, sugary foods, sugary drinks. If you eat fruits, it's okay. It has sugar, but it's kind of...
It's a low sugar impact.
But if you actually take sugary drinks or, these bubble teas, they're packed with sugar, all these granules.
Oh, God. Oh, you could tapioca little balls. Oh, yeah, those are slimy. Who wants to drink that?
Yeah. So...
milkshakes.
Yes, all those kind of things are pro-inflammatory.
Sugar in your coffee, sugar in your tea.
Yeah.
All that fun stuff. But I mean, I think generally trying to eat less sugar, we know in general is helpful, like good for your general well-being and your risk of cardiovascular disease and other things as well. So I wouldn't specifically do it just for acne. If you're going to, try to improve your diet generally, you're going to cut out that stuff too. If your acne improves, fantastic. But I don't think it's the reason why a teenager has acne, for example. It's not because
it's not alone.
It's not alone. So it's not like cut out acne cut out milk or cut out, gummy bears and suddenly your acne clears. That's certainly not the case. And I think that's what patients think. because I see that a lot. Like, oh, but I cut out all my dairy and I still have acne. Like, yeah, but
Well, it's helpful step.
it's helpful for general, I guess maybe for general, well, and to a point, but dairy is important generally anyway for health because of the vitamin, the calcium and everything like that. So I don't want patients to cut out eating an entire food group for their acne.
Yeah.
So,
but the fast food junk and all this,
it's
very beneficial.
Generally, yeah.
Yeah, and they're basically saying is due to insulin-like growth factor 1, levels go high, and obviously all this disbalanced insulin and receptors and glycemic control goes out of the window. So, and it promotes the growth of the, inflammatory spots, basically.
And it did say increased dairy, specifically increased dairy consumption may have been pro-acnegenic, so cause acne in select populations, such as those in which a Western diet is prevalent. So, I mean, we know the Western diet is not ideal for general well-being anyway. So,
British breakfast.
Yeah,
with all the fries.
Yeah, all the fried British breakfast. Oh my God, it's like 1,500 calories, like 600 grams of saturated fat, or whatever. It's like a massive carb load and a fat load with very little protein. I mean, that's not your ideal breakfast, I think, for anyone. But generally, I think the bottom line for me with this is just eat a healthful diet. You know what not to eat. Everyone knows what they shouldn't be eating.
Yeah, balanced
food,
fruit, vegetables, and protein. Cut out KFC and McDonald's kind of thing.
Cut out the full fat Coca-Cola and you're good. So
yeah, all these bubble teas, because I was shocked when I watched documentary. They said how many sugar spoons in 1 cup of the bubble tea is about 8 to 12.
Oh my God, that's more than like a can of
Imagine
Coke.
if you eat the sugar, you won't eat 8 spoons like this.
Certainly
but
not.
if you mix it in a solution, you can drink it, sip it, and
Oh, so stay away from those bubble teas, guys. Oh, yeah.
So this is quite interesting.
It's interesting.
It's logically kind of anticipated, and now the evidence says yes, it is not good for you.
Yeah.
Officially.
So we need official recognition of that. But I mean, that helps. Hopefully, that guides people with how they should approach their diet if they have acne.
Yeah.
So. All right, cool. That's a good. That topic is a big one, but we got it into a small.
There are also impact of diet and nutrition in patients with acne. Basically, it talks about supplements.
Oh yeah, this one. Yeah.
Because people say like, I take this supplement, I take that supplement.
Zinc is a big one.
I think selenium more pro-inflammatory apparently.
Oh right.
Yeah.
But zinc is the one people take for acne.
Zinc is good, yeah.
Zinc, and then we talked about omega-3s.
Yeah.
I mean, I think it's not going to cure your acne to take these supplements, but it can be perhaps helpful. Yeah,
they actually have a very nice figure on page 3. So basically it says increased GI, glycemic index, dairy, meat, they kind of lead to insulin growth factor 1, and then FOX01 or whatever, FOX1 is basically pro-inflammatory.
Yeah.
Because when we take NSAIDs, it blocks that kind of cascade. So that kind of inflammatory process. And it's actually, I think, remember we were talking about nano aesthetics, exosomes, little vesicles. I think we're going into molecular level of the disease now.
Oh, right, with all this stuff.
Yeah, with all these little things.
Yeah.
So, and sometimes people have predisposition genetically to diabetes, mom and dad. So it's just epigenetics, I suppose, is another factor into the mix.
This whole paragraph is like all these mTOR things. This takes for me, I have to read this really slowly and then look at the diagram to understand what they're talking about. But the advances in understanding of dermatology pathology is actually always, in the big ones like psoriasis and eczema and acne, is always ongoing, I think. So we're always trying to find more of an answer. Though I always say to patients, acne is one of the best understood dermatology problems, skin diseases that we know about. Eczema, psoriasis, and acne would be the 3 top ones that we kind of think we understand better. And like urticaria. Anything that there's a biologic for, I always think they wait for the biologic for acne. Kind of, I think that we know
kind
a
of,
more about it. Yeah, kind of, yeah.
There's a page, I just wanted you to check.
Yeah.
Page 10 talks about chocolate. This is controversial topic.
Such a controversial topic.
So it says double-blind placebo-controlled research you know,
this one, the cappuccino. Yeah.
14 participants.
14, aged 18 to 33. Oh,
So-
sorry, 18 to 35, only men.
Yeah, so this is straight away. It tells me that is not enough.
Yeah. Oh, it's certainly not
Power
enough
is not
power.
enough. No.
Yeah, you need more than 14 participants. But
Yeah.
what they gave them to eat is funky.
I think they gave them some sort of
A
cacao
capsule.
capsules and sweetened.
Non-sweetened 100% cocoa in a capsule, or one with gelatin dust in it, or a mix of both. Both capsules. I guess they swallowed them. Yeah, okay. And it was only 7 days.
Yeah.
It was 14
So these type
people,
of
7 days.
studies making headlines and saying like chocolate is bad for you,
Yeah.
chocolate helps your heart, and kind of.
I mean, you can get no information from 7 days. And also, acne takes longer than 7 days to form. A comedone can take weeks
Yeah.
even to go into a spot. And you need a comedone first, otherwise you won't get a pimple. So, this is a fairly almost useless study to me. I mean, I don't know if you agree.
Yeah. There is another one, 33 men, 17 young men, and 16 middle-aged men. So again, kind of anecdotal studies of chocolate.
Yeah, these
but
are like anecdotal
I
studies.
think maybe dark chocolate with no sugar of some benefit.
If we go eat dark chocolate. Now, if we go for if we go for the sugar route, that the sugar is the problem or can be the problem,
Yes.
then dark chocolate that has like no sugar in it. I mean, I quite like the 99% Lindt chocolate.
Oh,
Yeah, I don't know. Do you like that one? Can you get that in Dubai? I don't know.
very, very
Yeah,
black,
very black. Have you tried that?
very bitter. No,
It's very bitter. It only comes in small bars.
so I get almost like a crown. When
Yeah,
I
you
eat
can
that.
you can only eat like one square.
Yeah,
and then you're like,
that
I'm done.
puts you off
It's
for
not
the
like
rest of the day.
For the rest of the day. It's not like a Cadbury fruit nut. You can eat the whole thing like a giant bar in one go.
Yeah.
But no, I always feel safer if I eat the really close to 100% dark chocolate. So,
I suppose you can't eat a lot of that.
no, it's almost like cooking chocolate, you know.
Yeah,
Yeah.
I like Cadbury's.
Yeah, we all like Cadbury's. Fruit and nut all the way. And apparently the fruit nut Cadbury's in Dubai is different tasting than the one from the UK.
I think they're made outside.
Yeah, it's made outside the UK.
In
so
other countries.
I have some friends who ask me every time I go to London, which is not so often now, to bring back a Cadbury fruit nut, a couple from the airport.
Birmingham has factory. I went there for.
Oh, it does.
Yeah.
The Cadbury factory in Birmingham.
Yeah,
I know.
it's amazing.
It's
When you
amazing.
go there on a tour, you end up with lots of chocolates
Yeah.
because you collect from every attraction. They give you at the entrance, then everywhere else you go, and then you actually can cook and mix
Mix your
chocolate
own.
yourself in there. So I think it's so amazing, and and they have this classic red sort of color Cadbury chocolate.
Oh yeah.
You know the classic one?
The Bourneville. That's the dark chocolate.
Yeah, Bourneville.
Yeah.
So this is my most favorite.
Yeah, I love that one too. I think for health reasons I go with that one. But if I had a choice and could eat anything I wanted, I would go for the Cadbury fruit nut every day, maybe a whole bar. When I'm retired, I'm always saying this to you. When I'm retired and I'm old, like when I'm done with everything, then I'm going to totally. I'm going to just drink champagne for breakfast and eat Cadbury bars all day
and read the paper.
Yeah, read papers and have carrot cake for dinner. Like that's going to be my life after years of dieting and stuff.
You will
it's
end
gonna
up
be fun.
with acne.
I'll have acne and heart disease. I'll have a stroke, all within like 5 years.
Yeah,
and I'll be an alcoholic.
But
anyway.
life is worth it.
Yeah, exactly. You just get to that point. So, right, moving on from that topic, the next topic.
Actually, the another one paper on diet in dermatology.
Oh, yeah, this one. Yeah.
It's quite interesting paper from Journal American Academy of Dermatology, 2014. The good about this paper is kind of written for the CPD.
Oh, yeah.
And the key points for atopic dermatitis, they're saying prenatal followed by postnatal probiotic supplements decreases risk of atopic dermatitis. So basically probiotics are really good for the body. I think we suspected that, now we kind of know.
Yeah.
Postnatal prebiotic supplementation decreases the risk of atopic dermatitis. I mean, all these soured milk products, not the sugary yogurts, the kefir kind of thing. Here is very common, kefirs.
Yeah, it's really common here.
Yeah.
I don't know, does it taste? I haven't tried it.
In Eastern Europe, diet is very common drink. You literally drink it every.
Oh yeah.
So there is no C. diff as such after antibiotics. Yeah.
What's that called what's the Ukrainian word for that?
Kefir is called kefir.
Oh, right. I don't think it's called that in Poland. But I know it's the same drink. It's the same thing.
Yes.
I don't remember what it's called.
It's basically soured milk.
Yes, it's soured milk.
It can be different
Flavors.
It can be different fat percentage. It can be semi-skimmed and stuff.
I love that stuff when I was
You can make it at home even.
Okay, that sounds like a push too far for me, but I'll just go to Spinneys.
You need to try.
You need to try.
Elimination diet are only appropriate for patients who have a food allergy and have been proven to have food allergies. So all these atopic dermatitis patients who come and say, I stop eating this, don't. Unless if you have test-proven type 1 allergic reaction and you have to avoid because you can get anaphylaxis.
You can die.
Otherwise, you have to eat a little bit of everything.
What about the Dutch test? Do you know what I'm talking about? I think it's called the Dutch test. That nutrition test where they check like your saliva and your hair for food allergies.
I heard, but I don't rate it that high. Do you?
No, that's not at all. But I have so many patients do that test when they have eczema or even acne. They want to know if they're allergic to strawberries or something.
But then they're the same square one, the same
it doesn't
spot.
It doesn't give you any information. Yeah, I mean, it's the most useful, and it's a saliva or hair test.
Yeah.
I mean, we only do allergy testing for, skin prick, RAS tests are for more like anaphylactic, from what I understand.
This paper will tell at the end, they do the prick test of the skin, patch test, a blood test for allergens, and a challenge test when people come into controlled setting in the hospital, in pediatrics. They start eating certain food, observed blood pressure, oxygen, looking nurse sitting with them. If they develop anything, they immediately will fix them if anything wrong. So only these 4 kind of tests, even prick test alone on the skin is not diagnostic. It has to be paired with the history, with the even blood test, depends on what, Well,
it's different allergies too. Like there's no lactose intolerance blood test.
I'm not sure.
I don't think
Gastro,
celiac, yes.
Yes, celiac, yes.
Obviously, but that's an actual disease, like a proper disease. What's the other one? Celiac is the main one that we know is a proper. I mean, allergies defined as different things. You can have an acute anaphylactic allergy, where you're about to die, or you can have an allergy which affects your gut, like celiac.
Diarrhea, bloating, lots of symptoms.
I don't know any other. Lactose can do that. I think lactose and wheat are the 2 for that. And then you can have skin, like contact dermatitis.
Yeah, but this is type 4 reaction. It takes weeks to develop, and it's a patch test.
But to have a food, so it's to me, the food allergy thing with the prick testing isn't really relevant for dermatology.
It's part of our competence in dermatology, if you remember curriculum. Some dermatologists, depends on the center, do it themselves. If they have set up a nurse who can monitor the patient.
For a child.
For the child, for children. For adults, I don't see
I've
the
never
benefit.
seen skin practicing.
But no, I've seen it here, and people end up with scars because instead of prick, they cut. So I've seen the patient, she came for scars.
But why would you skin prick an adult?
I don't know. It's ENT specialty was doing. It's pointless. It's pointless. Yeah. Maximum you would do, the blood test.
You do like an IgE, like RAS test. Yeah, to see.
For children, it's a very, very beneficial test, especially when they're weaning off.
Yes.
The first few years of life. And I worked very closely with pediatrics in Leicester. It's a very busy clinic, allergy clinic next to us. And they have all these patients, with different ones, allergens. And it's actually beneficial. And sometimes they also pair it with a special test for certain allergens, proteins, for example, peach. Yeah,
the food.
You can eat inside, but you're allergic to actual skin.
Yeah, the skin.
So you can have a blood test to test if you're allergic to protein in that skin.
My goodness.
So if you peel it off, you can eat it.
Yeah. I don't like peaches that much.
No, it's example. For example, like I had a patient who was allergic to that, but if peels off the skin, no problem.
So what happened to that patient if he or she ate the skin of a skin of a peach?
Swelling.
Anaphylactics.
Yeah, it's getting shark mouth and swelling. Okay. Kids say shark mouth.
Yeah, so anaphylactic reaction is one thing, but you don't get in adults, generally you don't get eczema from a food allergy.
Not really. I never test adults for food allergy in eczema. I test them patch test.
Yeah, so if we think of contact dermatitis, yeah, of course.
Patch test, or sometimes, the house dust mite. We know all atopic dermatitis patients, there's paper came out, 100% allergic to house dust mite. You don't need even test. We know that. I always tell them that they still won't test. I said, it's pointless.
It's pointless.
You're allergic. But there are some people, mold, you know, all that kind of things, potentially like respiratory allergens.
But they don't necessarily make your eczema worse.
Not necessarily, no. But mostly contact, I would say. Patch test, for me, is essential.
Yeah, but that's for contact dermatitis.
But for some reason, people don't like the patch test.
Oh, no. Would you want 150 stickers on your back for 72 hours?
But it's...
You can't shower?
You wouldn't want it, but you would want the answer.
Yeah, I want the answers.
Because if your eczema flares up and you want any test under the sun, but this is the most informative one.
Yeah. Not a blood test. You need an actual physical patch test,
Yes. So this is the most informative, and only to prevent flare-ups is avoidance.
Yeah, avoidance, of course.
So if you don't know, how can you actually avoid?
And I think this is the contact dermatitis thing. This is what we mean by that is that you get an eczema-like rash or eczema when you come in contact with this allergen. For example, like you can have a contact. For example, this is a wood table. Some people have a contact dermatitis to the lacquer that's on the wood. So that means if you had that, if you sat here like I'm sitting and you put your arms down, you would get eczema in the areas that touch the table. And I think that's really confusing for patients. They don't realize you have to have contact with the item. So often with nails, they get eczema around the eyes because you touch your eyes with your nails. So it's kind of a Sherlock Holmesy type thing, trying to figure out what may be causing your eczema if it feels like it might be a contact dermatitis. And that's part of, when I meet an eczema patient for the first time, that's part of the whole history. You do that too. So we take that full history. So that's totally different. We need to do a totally different podcast about allergy generally in dermatology.
Yes, allergy, patch testing,
and blood testing. And also because I have so many patients come in, when I eat, I don't know, name a food. When I have this certain type of chocolate or this whatever product, I get eczema from it. And I'm like, well, that's not really possible. You're not getting eczema from the food you're eating. And to say that is almost, I can't even say that to patients now because it makes them really upset about it. Like, no, I know if I eat this red wine the night before, the next day I'll have eczema. And they link that connection, which is easy to do. I appreciate everyone wants to find a reason for their eczema, and that's something they can control. So if I don't drink red wine, then I won't get eczema. I think that's a natural human reaction. But then to try to get patients to realize that's not correct at all, actually, is extremely difficult. So I just let it roll. Like, yes, okay, fine. Eat. If you think it's affecting your eczema, then avoid red wine or whatever. I mean, how do you deal with it?
I don't test for food. Adults.
No,
children,
I never do.
And I even refer because it's so important not to miss that period in children.
Yeah,
in adults, I said, you're already grown up. You already met majority of allergens, right? So by now you would know if you're allergic to a food. But for me, it's more interesting your contact. Do you remember?
Yeah, of course.
Do you remember that publication, Sofa Dermatitis? Some sofas from China with the.
What was on the couch?
I think it was coloring.
Coloring.
Yeah, the
God,
leather
that was
coloring.
So fun. And the one with the toilet seat.
Yes.
Do you remember that one?
Well, I still see some patients. One patient came and there is a cleaning product they left on the toilet
and that caused
seat,
the dermatitis.
And the child came with the round rash.
Yeah, so that what we're talking about is obviously this is about contact allergy. So if you come into contact with something you're allergic to, you get a rash in those places. This is happening with toilet seats. It's quite rare, but it's always reported. And it's so crazy. So if you get an eczema on your bum in the shape of the toilet seat, then you may be allergic to something on the toilet seat. And that sofa thing was the same. Everyone who was sitting, or people who had a tendency to dermatitis, were sitting on the plastic dyed couch or whatever it was, and were developing eczema just where they're sitting on the couch, like just to their thighs, and then but you have to be sitting pretty much naked on the couch.
Almost.
Because it doesn't really go through clothing.
Yeah, almost. But I mean, sweating as well. Don't forget, if people sweat, it obviously can be.
Can be, yeah.
And do you remember that MIMCI allergens, the preservatives in the paint, which they start putting instead of parabens in their skin creams and shampoos?
Clarence made that switch a few years ago.
Yeah, everybody, almost every brand had it. Now it's completely banned in leave-on products, but still available in shampoos and conditioners. And people, once they become sensitized, it never goes away.
Never goes away.
Even if they walk into freshly painted room, they flare up because airborne allergen.
It's airborne allergen, yeah.
Yeah. So this is something terrible that parabens don't cause that much problem.
No, parabens aren't an issue.
But once you replace with something terrible.
To make it safer.
Yeah. And it was like a pandemic tsunami. It was a year of MIMC allergy.
How many years ago was that? That was,
I think
I was a
five.
registrar.
Five.
Oh,
5 or
years ago?
6, yeah.
I remember the Clarins thing being a huge issue because we had all the people who use Clarins makeup suddenly were getting reactions to it.
Clarence Spa, they went for masks and come back with the red, terrible,
We're not vilifying Clarins, but that's the one that I specifically recall with this issue. I think they may have been the first one to start it.
No, it's almost every brand had it. They did not realize that it's going to be the issue.
And they did this change of preservative, because these are preservatives in skincare and stuff. So they did this preservative switch because there was so much in the media about how parabens are unsafe. Now, we know parabens are not unsafe in your skincare.
No, they're
not.
They're
totally fine.
Yes.
As, they're in everything. So, but in the attempt to alleviate the stress of the consumer because they didn't want to buy the products with paraben, the skincare companies were like, hey, we'll use this other one, but actually they caused a huge problem using the other ones.
Now we're back to parabens.
Yeah, we're on parabens now, but this is a good reason why, we shouldn't be following almost like sometimes, okay, yes, we should listen to the public, but sometimes the public is wrong about stuff, and these misinformation things are incorrect.
I think.
And they're feeding into the public, and then everyone starts to freak out when actually there's nothing to freak out about. And then what the consequence of that is that things change in an unnecessary way. So the misinformation is causing loads of problems. But this is a big one. It's catastrophic.
It's kind of snowball effect. It's like a labubu, very popular now.
I'm not a fan of those. I'm sorry.
But it was just a toy, and now suddenly everybody obsessed with that. Same with parabens. It was just parabens. Nothing was a problem.
No problem.
Now everybody got obsessed with
about it. Yeah.
So anyway, right, carry on the topic.
Do you have one of those?
No.
Okay.
I don't follow trends. I'm more into vintage kind of stuff.
Yeah, I like a bit of vintage too. But yeah, I don't have one either. It will never touch on my handbag, Labubu. So, was that with a Labubu?
Yeah, Labubu.
Yeah, no, I'll never. And
they have
some
Labubus names. I don't know what they are.
But now they're going for like £400 on like eBay. There's no way I'm spending that much on
But it's a genius structure
marketing.
Of marketing. Genius. You just look at that person and you learn.
Yes.
How to become Labubu. Genius.
Like 10 of them hanging from bag. Yeah. Anyway, all right.
And there are a few other points. We're going back to points. Maternal allergen avoidance diet does not prevent atopic dermatitis. So pregnant women should not cut out things of her diet.
Right. Yeah, definitely not, especially when you're pregnant.
Well, people do. You would be surprised, isn't it? Yeah. Exclusive breastfeeding and supplementation with hydrolyzed formula is protective against atopic dermatitis for high-risk infants. So those who have very strong family history and very high risk, yes, exclusive breastfeeding is helpful. For others, it's just normal risk.
Right.
And we know that vitamin D is very beneficial for any age, and even in melanoma prevention, when we see patients with melanoma, we always measure vitamin D. Prebiotics on all this healthy bacteria are very beneficial. So basically...
for atopic
dermatitis.
Which is eczema, same thing.
Yeah, there are also some key elements, non-melanoma skin cancer as well.
Oh yeah, that was in here too.
So a large randomized controlled trial found no significant effect of low-fat diet in non-melanoma skin cancer. Therefore, fat restriction diet should not be recommended in non-melanoma skin cancer, which is BCC, SCC kind of thing. Selenium supplements may increase the risk of squamous cell carcinoma and total non-melanoma skin cancer, and it should be avoided, apparently.
I mean, selenium is all the multivitamins you buy.
Yeah. So, and then another one, the effect of retinol and retinoid supplementation on non-melanoma skin cancer varied based on risk factor, comorbidities, and cancer type.
So, these are oral acitretin or topical tretinoin?
Both.
Or oral vitamin A?
Yeah, both. I think what I usually say to my patients, if you use prescription strength retinol and you have mild sun damage, which is not like a full-blown actinic keratosis on BCC sprouting, is beneficial.
Yeah, I say that too. That's a tretinoin, basically retinoic acid. Yeah, it doesn't protect you from sun exposure damage, because that's where you have to clarify. This is not a sunscreen.
No.
But I believe it's over a certain amount of time of usage. So regular usage over, I think, 6 to 12 months, then is protective from further sun damage, but not protective from sun. So it helps. No. Yeah, it helps. It's almost like a prophylactic treatment, I would say, to further non-melanoma skin cancer.
We know it's rejuvenation. We know it's the only proven that stimulates collagen, elastin.
Yeah.
Everyone goes on about collagen. Collagen is scarring. The more we stimulate collagen wrong type, it's scarring. We need to stimulate
The
correct
right type of
collagen and elastin.
And is there anything that stimulates collagen? We don't know, because you can't isolate collagen. Which one is it? Collagen 1 and 3 are the correct types?
Yeah.
Yeah. So can we isolate collagen 1 and 3? No.
And collagen supplements, I don't think is any evidence that works.
No.
So
Nothing.
far, even if you put it on or you drink it in or
eat a gummy.
An injection nowadays, do you know the injection collagen?
Yes. Does that do anything? No.
I actually monitoring this because I don't think it actually does as much as it says, but I'm still monitoring for the evidence.
Yeah, because I don't think there's anything yet to say anything anything positive about that. I think collagen is really overhyped, but it is. So, like, for example, I'm just now we're going on a tangent about this, but Sculptra, Radius, these kind of biostimulators, the collagen stimulating injectables, like the polylactic acid and Radius.
They create scars.
Yeah, right. So it's meant to, by dissolving, it's meant to stimulate, polylactic acid, Radius, stimulates the formation of, or creates a scaffolding for the formation of new collagen within that. But you don't know what kind of collagen you're creating.
You inject calcium hydroxyapatite or you inject acid. It's foreign body.
Yeah.
So body produced foreign body reaction. So it's not a healthy 1 or 3 type of collagen. It's a foreign body reaction, which is granulomas. And that granulomas theoretically make your skin tighter, but it's scars.
Yeah.
So it's not, if histologically you look, it's scars, right? So, and all these threads, foreign body, which forms foreign body granulomas. It's literally a scar's body trying to surround it by all these cells to separate from it. So it's not type 1 and 3 collagen, which you're trying to. But look, if you look at the histology, when there is a severe damage, sun damage, we call it elastolysis, elastin. Not collagen, elastolysis. It's a blue mashy,
blue, isn't it?
Blue mashy blob instead of nice structures. I usually say like French fries, nice block structured, and then it's mashed potato. Yeah. So basically, we're focusing on collagen too much. It's important, but we need to focus on elastin.
So how do you? I mean, I don't think there's anything that. What stimulates elastin formation?
I don't know. It's nothing.
Nothing. That's why no one focuses on it.
But I think the retinols possibly do help with that aspect. Not that significantly, but they do help to a degree. Yeah.
Yeah.
But I think it would be nice to see more trials on elastin stimulation, because elastin makes your skin elastic, all this dewy, nice looking.
And keeps it tighter. But even treatments like the heating up the skin treatments, like ultrasound type stuff, and all those. There's many names for the same thing, but you know what I mean, like the
ultrasound heating,
radio frequency, these kind of things.
But it's trauma induced to the skin, and skin reacts to trauma. How? Imagine you cut. How skin reacts?
Contracts.
Yeah, contracts, forms scar. And it's not type 1 and 3 collagen. It's a scar. And then you form keloid scar, you form, the lumps, whatever it is,
But that's if these heating up type devices even cause that much damage, enough to cause the collagen to have to, I don't know, to cook. I mean, you cook it, but does that mean you're going to make I guess it's a damage to the skin, so... Yeah, okay.
But
I get it.
When you look at those people who use these machines, they end up with facelift anyway in the future.
Well, of course they do.
So if it was so effective, you would end up with continue that and still look young. But they end up with facelift. I don't think anything is better than facelift properly done by experienced person.
Exactly.
Now we're looking at minimally invasive facelifts, like when they cut little bits here and there. And I think that's what we're moving into, endoscopic, Maybe they will create something else which will be absolutely minimally invasive. Like we have laparoscopic surgeries for gallbladder. Maybe we have endoscopic surgery for facelift.
But you can't yet, they do, I know brow lifts can be done endoscopically. I don't know if lower face can be done endoscopically. That's outside my skill set.
I attended a conference which was mixed, and Dr. Kayo, a very famous surgeon from the US, he puts the thread in a way, I'm not a plastic surgeon, but what I understood, he puts in a way that it actually anchors all lots of points, and it's like
But not a thread lift. He's suturing.
No, it's suturing.
Yeah,
it's
he's not going down like this. He's
endoscopic right plane, the deep plane in a way. And now I know a lot of surgeons do that instead of cut the whole thing off, because we know when we cut, the sensation, the nerves, we can't feel anything. And here it's very weird to live with no feeling around. Nobody talks about it, but you have no feeling, sort of numbness.
Oh, yeah, patient told me.
Yeah. So, but when they do an endolift, and they lift the correct way and anchor to the correct place, because you have to anchor it to deep tissue, not to move. So when he showed, it was live demonstration. I think it was CAS meeting.
Oh, yeah, CAS meeting.
In Paris, I think last year.
Last year, yeah.
So what he was doing live demo, and it's amazing. You know, he does this thread. It's non-dissolving thread, but it stays in a patient, and it lifts. And some people 10, 15 years down the line, they still have good result.
That's amazing.
So instead of doing this invasive, we're moving towards nano, micro, molecular level, endoscopic kind of minimally invasive life, hopefully.
But generally. But hopefully when this becomes less of an invasive thing, because patients are scared of the mega surgery involved in a facelift, which I understand, all the downtime and everything, well, there will always be downtime, then perhaps we'll stop messing around, or the skin industry will stop messing around with these non-invasive, heating up the tissue, nonsense type of facelifting devices, which are a hugely expensive thing to do, but also minimally effective, if at all, from the generally.
Yeah. I absolutely love IPL, intense parasite. I find it so beneficial, and there's some evidence that it's quite effective as well. I really refer a lot of patients for that, and beneficial.
Yeah, I love IPL. Yep, I love IPL. I love CO2 laser, but that's slightly different. That's also heating.
But there's a lot of evidence it works.
Yeah, there's a lot of evidence too, and also CO2 does the resurfacing, which is very important. It's like sandpapering your skin, but in a very specific way, and that does give you that rejuvenated skin appearance. So we know CO2 is well evidence-based, IPL is well evidence-based, and but everything else is not really well evidence-based. So I mean, I get questions about every single device on the earth every day, and I'm just like, well, I just do CO2 and IPL, and that's it.
And we actually have, I think I sent you the paper.
Yeah, we have a paper on this.
Which one was it?
It's the one about
1.6. Yeah.
1.6. Oh yeah, 1.6.
So I sent you a separate email.
Yeah, I got that.
So it's basically in Journal of Clinical and Aesthetic Dermatology. So established and emerging laser treatments for acne vulgaris in diverse skin types. So basically,
acne. Yes, so, yeah, I see it. Yeah.
Acne one. The lasers in acne specifically, people want anything alternative to Roaccutane. So the conclusion is they can be effective, primary or adjunct, but obviously we don't have enough evidence. We don't have large randomized trials. We don't have trials which performed with a control. Mostly they done half-face split studies.
Yeah.
And patient not blinded, assessor not blinded. And so because you really wanted to have for it to work, the scores are going quite high, right? So it's quite biased. For skin 1 to 3, there are good sort of variety of lasers, but the darkest skin, we're a little bit stuck there, isn't it? We have to be careful.
Yeah, we have to be careful. Roaccutane is better. But what's interesting is this, they go through in this study the visible light, the KTP laser, the pulse dye laser. Pulse dye is the most extensively studied laser for treating acne. And then the next ones are the ND-YAG. And then they went into the mid-infrared, which are the 320s, 1450s, and the 1927, but not the ones we're talking about sebum absorption. So that would be what we know as your Acure laser, or whatever the other brand name is from the other company. Can't remember. Acure and the other one. So these are very expensive treatments that are offered all over Dubai right now for acne as a alternative to Roaccutane. There is no strong evidence base at all to show that these are effective over a long period of time. There's no guarantee of clearance with Roaccutane. We know we understand the mechanism of action. We know what's going to happen at the end. But with the Acure, these types of newer lasers which target the sebum sebaceous gland in the skin, for example, which that sounds weird as well. But anyway, they're just not effective. It's so expensive, though. We're talking like 4,000 to 5,000 dirhams per treatment. You need like 6 to 10 treatments.
I absolutely don't look that direction with the lasers
Oh,
and
you don't
acne
look,
at
I do.
all.
That's funny. Well, not intentionally.
But I came up to across this study, and basically says to me there is no laser that is the most effective or superior to any other treatments we have.
And that paper was published this year.
Yeah.
It was.
And
I don't know the month,
cross-reference 109 other papers.
I mean, that's a pretty damn
So
well-referenced
at the moment we
paper.
have to wait. There is no kind of laser that will cure acne.
And just as a reminder here, the 1726 laser, which is the one I'm referring to, that targets the oil glands, that's been FDA approved for safety, but not efficacy. It's a device. So it's very different. So a lot of these companies, and I've looked at a lot of the marketing of websites for different clinics and stuff that are having this laser, they talk about the FDA approval. And they're like, oh, this is FDA approved. But people don't know what that means. They think it means it's safe and effective. It means it's effective. But that's not what FDA approval for devices means. It means it's safe to use and it won't kill you, basically.
Yes,
or harm
as a
your skin.
device,
As a
and
device,
not as a treatment
not
modality.
as a treatment. So that is what's so important to remember when you go to see an aesthetic doctor, because most dermatologists wouldn't recommend these lasers because we know better.
Yeah.
Yeah, I mean, if a consultant dermatologist is recommending you this funky, very expensive laser, I would probably suggest you get a second opinion from another consultant dermatologist. But if you go into these clinics and they're like, oh, we can do this laser, this facial, and do it all in a package, you need to think about this and kind of say, maybe this isn't the right way to go, and perhaps get a second opinion.
And look, these studies, 12 to 18 weeks only. So we know with Isotretinoin, years evidence of acne being sort of stable.
Decades.
Here, 12 to 18 weeks. So there are studies not long enough. And when we look at the number of participants, 30, 60, 62, 19, 14, 89, it's not actually many participants per study, And the follow-up only 4 weeks to 12 weeks, that's it. It's really poor evidence here.
It's poor evidence, but it's also not curative. And though acne, I appreciate, everyone's like, oh, there's no cure. Technically, acne is the closest thing we have to cure because it changes the way the pilosebaceous unit functions. And that's the closest we can get. And if you take the right course with the right amount of treatment, then your risk of relapse over the next lifetime, your lifetime, is very, very low. But none of these lasers can do the same. They're all like almost symptomatic treatments. They make you a little bit clear for a little while, but then you have to keep doing it.
For a few weeks,
and who can afford to, most people don't have the time or the money to do this type of treatment every month forever.
I think it's false perception that it's quick, it works.
And it's safe.
Yeah, Roaccutane you have to take for 1 year or longer. This one is like a few weeks and you're done.
It's absolutely not true. But also, it's cheaper to see a consultant dermatologist like you or I and get a prescription for Roaccutane and get the blood test than one session of one of these lasers.
Oh, almost for the whole year of Roaccutane.
You have a whole year of Roaccutane. It will cost you less than 4,000. If the treatment is 4,000 dirhams, you can get your entire acne treated for less than that with Roaccutane, I say guarantee effectiveness, but it's as close to a guarantee of effectiveness I can get for any treatment ever.
Yeah, this is the most effective treatment we have at the moment.
And it is safe. So talk to your doctor about that if you're concerned about safety. But this is a really interesting paper. Yeah, it's a good one.
So this is a good one, yeah. Shall we move on to Minoxidil? You're a specialist in Minoxidil.
Oh, yeah.
You will, 6.1, I think. We skip a few more on nail psoriasis if you have time. We've got only 20 minutes.
The dermatoscope one.
Do you want a dermatoscope to do?
Should we do that first and then go into Minoxidil?
Okay, so
that's a good one.
We have another paper, which is 2.1.
Yeah. Skin
cancer diagnosis by lesion, physician, and examination type, systematic review and meta-analysis. So it's in JAMA. So basically, this was assessing 100 studies and looking at clinicians, how the skin cancer was assessed, what tools they used, and what expertise of clinician. Basically, the conclusion is the highest pickup rate of skin cancer is by highly trained clinician who using dermatoscope. Mm-hmm. And dermatoscope is a special tool we use in dermatology. I absolutely can't imagine how you can assess anything without dermatoscope.
I agree. Absolutely.
And it times 20 magnification. It has polarized, non-polarized light. Now we have extra more modalities which give extra benefits. And basically, naked eye gives you very low pickup rate of cancer compared to dermatoscope. So and highly trained clinician a lot more effective in picking up skin cancer, up to 89.1% to 91.3%.
I mean, that's almost 100% accuracy.
Yeah, obviously there are some AI tools which can be more accurate, but again, they're trained by doctors. Right?
They're only as accurate as we are.
Yeah, and there was a study as well looking at AI. At the moment, there is no AI which can diagnose on its own. It has to be adjunct to clinical examination.
Of course.
So I see the patient, examine them. If I have any concerns, obviously I biopsy or monitor. Certainly we can employ AI for people who have multiple hundreds and hundreds. You literally physically cannot look at every single. But then you go back again and look at those moles highlighted by the AI tool.
Yeah.
And reassess the patient manually again. So the false perception that AI is better, yes, it's good when it is updated, well-trained and functioning, but there is also drawback. At the moment, we can't have AI approved to be used in medicine because sometimes they're not updated and we don't understand when they actually start misdiagnosing.
No, it's true, yeah.
You know, like, because there's a point when they start misdiagnosing and missing, and I think we're not sure how to deal with that.
Yeah, I mean, you just can't rely on it. It can help you flag up things perhaps, but I mean, I still wouldn't use that as a diagnostic, tool on its own, AI. But when you say AI, you don't mean mole mapping, those mole mapping machines that take photographs. That's different. The mole mapping machines can give you an opinion, though, about the mole.
Oh, it's helpful adjunct to my manual examination. It's not replacement.
No, it's like how helpful is an adjunct, do you think?
I find if patient don't have many moles, I don't need it. But when they literally covered and freckles and moles, I think in those cases it's very beneficial. And plus, if I monitor them every 3 to 6 months, when I have photos next to each other, it's great.
Well, for atypical dysplastic nevus syndrome, which is back when I was a trainee, we would do non-dermoscopic photographs of their whole bodies.
I remember, yeah.
Yeah, remember this? And we'd have the printouts in the file.
Yes, I remember.
Yeah, and you'd go back and you'd look.
Yes.
So, and that was because we wanted to see if there are new ones or they look different.
Yes.
And that's just normal photography. What we're asking the machine to do now, I guess, is take dermoscopic images of every single mole on someone with atypical. So dysplastic nevus syndrome means that you have just tons and tons of moles, like way more. People always think they have lots of moles, but you haven't seen a lot of moles until you see someone with this type of problem, which literally the whole body is covered. And in that situation, of course, we cannot look at all of them, like Volha said, we can't do that. But whether mole mapping, I think in that situation, mole mapping, as in taking the photographs and dermoscopic ones as well, can be very helpful.
Yes.
But I don't use mole mapping myself. I've always had it available to me wherever I've worked, which is interesting, but I've actually never sent a patient for mole mapping. But I've never had a patient recently, I haven't had a patient for years with properly dysplastic nevus syndrome.
It's very rare.
It's very rare.
It's very rare. And there's also paper concludes that actually a clinician who is highly trained is essential for actually the picking up skin cancer. You can have dermatoscope, but you don't know how to use it, so you won't be able to pick it up.
So what's a highly trained clinician?
So in my view, I personally had course, diploma in Australia.
I have a diploma, yeah.
Yeah, in dermatoscopy. So this to me, good enough to be able to learn, because facial lesions different to acral lesions, different to child, different to elderly, and different to pregnant.
Yeah.
So this all varieties, variations, it's important to pick up. Even lesion on the back, different to lesion on the abdomen or genital skin. Yeah. Because it's all special sites.
Special site needs, chest,
exactly.
breast.
So this kind of training, I would say accredited, reliable course that will be highly trained, plus obviously supervised for a period of time.
Yeah, we're talking about dermatologists here, consultant dermatologists. We're the only people who get this training. Yeah. So your first go is to find a consultant dermatologist who's properly trained. And then the next thing is to look you can check if they've had some kind of extra dermoscopy training. But from the type of training we've had in the UK, the baseline is that you're an experienced, by the time you finish training, you should have tons of experience already by the time you finish, and you know how to use dermoscope. I mean, it was required for us to take the dermoscopy diploma or whatever it was. I did mine in the UK. It was such an interesting course. I really loved that course. I loved dermoscopy. So
Yeah, I was actually trained with Professor Kittler and, Rosendahl, and he even came to Oxford, I think 7 years ago. They did the big conference for a few days. And there are a few schools of pattern recognition and, the descriptive terminology. Either way, wherever you are, you just form your own diagnostic sort of criteria, AI, like in your brain.
yeah, definitely.
As long as it works for you and you're kind of on the right track, that's perfect.
Yeah, exactly. But that is a very specialist technique that really only consultant dermatologists are trained in. So, for proper mole assessment and mole mapping, you want to definitely see someone who has that type of training.
Yes, look, if radiologists didn't have training in reading CTs or MRIs.
Oh my God, can you imagine?
So it's similar, like dermatologists have to be trained in dermatoscopy.
Yeah, exactly. I can't read a CT. Oh, I can see basic things on a scan, but I wouldn't be able to tell you lots of detail.
But you need training.
You need training for that.
Because your eye needs to
training.
have pattern recognition.
Exactly.
It's all that kind of connection, pattern recognition, and your own AI mechanism.
And that's gained through experience. So you build your AI through your experience, your own personal. But no, I mean, the dermoscopy is so important. I think, and understanding what it does and how it does. Because patients always ask me, how do you know if my mole is not cancer?
Yes, that's the question.
Yes, the question.
Training, through the training.
I've trained, and I've seen about 60 billion, I don't even know, moles in my lifetime through a dermoscope and visually, and I can tell you.
And it's not only that. When you refer patient for excision, the histology comes back. You do photograph before, and then your kind of histology comes back. You look at this, and it's possibly not what you expected.
Exactly.
You learn. It's like a audit on your own practice in a way, reflection and learning.
Yeah.
So this is possibly the very, very firm way of learning. It's not only, it looks like this.
Dodgy.
Yeah, dodgy. Yeah, let's cut it out.
Let's
Half
get
of
it
your
out.
cheek removed, that's it.
No, absolutely. So I'm just going to write this now for a note for myself. But yeah, I mean, that can't be substituted. That kind of learning is ultimately the best. And that's why we have all those meetings when we're training to look at them. Okay, should we move on to Minoxidil?
Yeah, now it's your time to shine. You're a Minoxidil expert, because I very rarely prescribe Minoxidil, and I'm still trying to see if this, topical compounded mixtures versus Minoxidil of some benefit.
Topically, you mean?
Yeah, so there are 6.1, 6.1, yeah.
So, yeah, there's two papers we have. One is we'll go for the first one. And just to mention, Volha is the one who finds these papers, and she does only take them from top journals, so high impact level journals. So the Journal of the American Academy of Dermatology, the JAD, the Journal of the American Medical Association, the JAMA journal,
BAD.
the BAD, the British Association of Dermatologists, the BJD, which is our journal. These are high impact level journals. They're not like crappy little, random. There's a lot of crappy little random journals. So it's important to get a paper, because usually if you get a paper from a high impact journal, it'll have really been checked by editors, properly reviewed.
A few reviews usually,
reviewed by the editors of the journal to allow it to be included in the journal. So that's what we're always kind of looking for. So both of the papers that we have about Minoxidil are from the American Academy of Dermatology, and let me just go through this. This one is a hit the thing. So this was almost like a systematic review. The first paper published was actually 2020. Systematic review of 17 studies with 634 patients using oral minoxidil as the primary treatment for hair loss. And the most common condition that this was used for was androgenetic alopecia, which is age-related hair thinning in both men and women. But there was also other ones like telogen effluvium, like post-pregnancy, for example, and different types of other skin conditions like alopecia areata, chemotherapy-induced alopecia. And generally speaking, in conclusion, they found that oral minoxidil is found to be effective and well-tolerated treatment alternative for healthy patients having difficulty with topical formulations. So the standard FDA-approved treatment that's safe and efficacious for hair thinning is topical minoxidil. The 5% for men, theoretically, and the 2% for women. It's licensed for treatment of hair thinning for people between the ages of 18 and 65. That doesn't mean you have to stop it when you're 65. It just means that the studies were done and the FDA approval is for that age category. But you can still use it if you're younger or older. Just get advice from your doctor about that. Topical minoxidil is super safe. It has minimal absorption into the body at all, really. And it does definitely cause hair growth if used continuously. And by continuously, I mean almost certainly forever. So everyday application to the scalp. It comes in different formulations commercially, so you can buy it on Amazon, you can buy it spinnies, whatever. And it's a foam, a solution or serum, it's a watery liquid, or a spray. So those are your three options. You choose the one that you like the most. I generally recommend the solution or spray for most people because it's, sorry, not the spray, the solution or serum, because it's a watery liquid. You just drop it on your head. It's easy to use. It will make your hair grow wherever it touches. So if you get it on your ears, I've seen this happen.
Cheeks,
ears, cheeks, forehead. I mean, I have seen people grow hair on their tragus where you don't even think you can grow hair, but you can grow hair anywhere except your palms and soles. So on your ear here, I mean, we don't want hair there. So you have to be careful with the application of it.
Some men would love to have hair anywhere.
Yeah, just put it all
in
over
this area.
I mean, technically you could perhaps do that because it's the same terminal hair as you have on your head, but it can also it can make you have terminal hair or darker hair growth on your face. So just don't get it on your face, please. But it does involve nightly use, and though minoxidil is very liquidy, it can make your hair feel a bit like greasy, a bit like
not
I don't know,
clean.
slimy. Yeah, in the morning, especially if you have fine hair. So most people who have hair thinning and want to use this have finer hair. So if you have that kind of hair, it's going to make it more lanky, and people don't like that. So though that's a very good treatment, it's a very safe and effective, and it's easy to get a hold of, it's not ideal for many people because it does impact their daily quality of life, basically. So the alternative is oral minoxidil, and that's the same medication but put into a tablet, and that's where it originally came from. So the use of oral minoxidil for blood pressure in patients in the 60s and 70s, and I don't know what that means, 60s and 70s, and they found that when they take oral minoxidil for blood pressure, but this is like 10 times the dose we use now, was effective for hair. It caused them to grow hair on their heads. So that's where we extrapolated the topical from, and that's how that happened. But going back to the oral minoxidil, over the past few years, I've been using a lot of oral minoxidil with my patients for convenience, for cost effectiveness.
What dose do you start and
I start people
maintain?
on one. Okay, so it depends where I am. So ideally, I'd like to start people on 1 milligram. It's not available commercially as a 1 milligram tablet, so I have to have that made in a compounding lab. It's not terribly expensive, but it's more expensive than commercial. The commercial is super cheap. In the UK, because right now in Dubai, I can't seem to find commercial minoxidil for some reason. We're still looking at every pharmacy. It used to be available, but now it's kind of gone. So I have to have it made. So here, 1 milligram is what I start people at. For men, I usually start 2.5.
And do you keep them on that?
No, so I change it. So it depends on the response. For men, I can go up to 5 milligrams a day because they don't mind about body hair growth. So the only side effect of, and it's dose related, I think, is that is the hair growth. So you can have hair growth anywhere from it. So eyelashes, eyebrows, face, and literally anywhere. Now, most men don't care about that. So
they love it.
They love it. They're like, beards, yay. And men, if I put them on like a higher dose minoxidil combined with Propecia, which is another medication for men, then their hair growth is phenomenal, and because they're consistent with it. The topical is not so much. So that's great. For women, it's also great, and women take the tablet consistently and also have great hair growth. These studies are good because they kind of back up that fact. So it's effective and well-tolerated treatment for people who can't stand the topical. The topical also can be irritating to the scalp, so that's also a reason people start using it.
Yeah, some people like foam more than liquid,
They do.
less irritating, depends on the preference.
Yeah, and this one, so looking at oral minoxidil as monotherapy compared with using it immunotherapy with finasteride or finasteride.
Yeah.
So this was and it starts with saying low-dose oral minoxidil is a safe, efficacious off-label treatment for androgenetic alopecia.
Yeah.
And then finasteride, dutasteride are the 5-alpha reductase inhibitors, which are primarily for men. And I can't remember what the conclusion was, but I think the conclusion was favorable.
It's safe, and low-dose minoxidil is effective. We know that high dose, it had lots of side effects. People struggle to tolerate. That's why this is not used for the high blood pressure anymore.
Yeah, exactly.
But the low dose, quite effective and safe treatment.
And they use the standard doses, the commercial dosages, which is like cutting a 2.5 milligram tablet into 4 pieces, which is incredibly difficult because it's a small tablet. So it's 0.625 milligram.
Yeah.
But they base this purely on the fact that they can't get it another, with compounding, you can make it any dose you want.
Yes.
Which is fantastic. So 1.25 milligram, 2.5, and 5.
Yeah, you start small and then you slowly start. What the maximum dose to females would you give?
For minoxidil, I have given them 5.
5
I've taken 5.
Okay.
And it's I haven't had any excess hair growth anywhere, but I just went straight to 5 because.
Any other side effects? What described in the label? No. Tolerated quite well. No problem.
Nothing. I've never had a patient, aside from the hair growth, have any, side effects in terms of blood pressure, dizziness.
Nothing like that.
It doesn't really affect blood pressure very much. And, for me, I'm already on antihypertensive, so it wouldn't have mattered very much for me. But I found that, I know that I could have taken half the dose or a lower dose and probably still would have had a good effect, and I am going to change my dose. But I just wanted to see what would happen with the hair growth on my body from it. But I didn't have any problems. But the evidence suggests it's about 20% of patients who develop body hair growth from the use of oral minoxidil.
Yeah, it's important to tell people, and they will decide if they want to use it.
And a lot of people with certain ethnicities are not keen, so they will absolutely say, absolutely not spend my life getting rid of my body hair. There's no way I'm taking this medication. So, it's per patient, obviously. But it is very safe, it is very effective, and it's a great alternative to topical, but you do need to get it on prescription from your doctor.
Yes, prescription monitoring. What is your experience? The last question, I think we've got a few minutes. What is your experience with finasteride, dutasteride, all this kind of, I suspect, mostly males?
For mostly men. I use it topically in females as well, but for men I use it orally. I think it does help the effect of the topical minoxidil and the compounded formulation, and I also add tretinoin to that. Yeah. There is some evidence to suggest that a combination is more effective than minoxidil alone. With the oral, you mean the male experience with taking, what was the question? I can't remember.
So, the tablets, finasteride, dutasteride.
Oh, the finasteride, yeah.
How do you find it? Because I don't prescribe to young men at all.
Oh, I do. Oh, gosh, I do.
Because when I discuss side effects, they're like, I don't want that.
I always tell
elderly, older men and elderly who are already on prostate treatment.
Yeah.
No problem.
No problem, because they're already on it.
But the problem is they lost a lot more hair by then.
Yeah, well, with everyone, all males, I say there's a risk of developing erectile dysfunction, and that can be permanent, though it's extraordinarily rare. 0.01% of some studies show a really low occurrence of that. So I say, if you feel any changes like that, you just stop taking it. And I've yet to have a patient stop taking it. And I give all age groups. Yeah, and 18 and over. I have a lot of young lads who don't want to look like their dads, so they start early. Whether or not it's beneficial taken early, that I don't know. There's not much. I haven't seen anything about that. Like if you start taking it when you're 20, does that mean you will have less hair fall like your dad did in his 40s? And that's 20 years down the line. We don't know. No, I don't know. Hopefully it does.
Yeah. So I find compounding, when they have all this compounded, they like it. The maximum 2%, I think, finasteride, you go into topical, isn't it?
Yes, I do too. You do more because the compounding lets you have that, but I do 2%.
Yeah. So I think they like it because they get benefit. I'm yet to convince anyone to start finasteride, dutasteride. I think dutasteride better tolerated with minimal side effects.
Yes. Yeah. I've not ever used dutasteride. I have one patient takes it actually. Yeah. He requested it.
Yes, dutasteride. In my master's course, when I went, the professor from Ireland, he was teaching on his hair transplant specialist. He said dutasteride he likes more because hair transplant better growth
I might
after.
have to look into switching.
Yeah. So and apparently side effects.
Minimal.
Much better than finasteride.
Yeah, I've been meaning to perhaps change it. I need to see if dutasteride is available here commercially.
I think it's something available. I think pharmacist came and mentioned something.
In Dubai?
Yeah.
Okay, I'll have to check because I know finasteride is readily available.
Yeah.
So, I might start switching people and seeing how they do. But again, I've not had any problems with finasteride. So,
that's great. But,
it's great.
But, we had a BBC documentary when a young male, he was describing how it ruined his life.
Oh, yes, I remember this.
And I know it's 0.1%, but it's 100% to them.
Yes, of course.
But and they have to understand that.
Yeah.
And they have to agree to that.
Yeah, exactly.
And nowadays, in UK, we take consent for isotretinoin in writing for children, for libido and So I suspect possibly with this medication, it's kind of
to me the
same consent required because it can be quite important for them for the rest of their life.
Yeah.
I always say to people, okay, you don't grow your hair, but everything else is all right.
Yeah, you're fine everywhere else.
Yes.
Yeah.
But it's your
choice.
It's a choice. This is the option for you if you're happy. Yeah. Somebody will say, I don't care about anything else. I want my hair.
Yeah, a lot of people say that.
Yes, so it's personal.
Yeah, cool.
Great. I think we've done quite well today.
Yeah, totally.
I think we still had some papers on psoriasis and eczema, but we leave it for later, maybe.
Next time. Yeah.
So great, thank you so much.
This is great. Thank you for finding the papers.
Informative and
I'll find the papers next time.
Useful. Maybe next time we do a bit more cosmetic side, like polynucleotides and something else.
Yeah, absolutely. Great. Thank you so much.
Lovely. Thank you.
Bye.
Bye.